Hello, my name is Dr. Florencia Halperin, and I serve as the co-director at the Center for Weight Management and Metabolic Surgery of Brigham and Women's Hospital of Harvard Medical School. I'm delighted to be speaking with you today about the management of obesity. I don't have anything to disclose. What we're going to talk about today is the clinical management of obesity. And at the end of a class, I'm hoping that we will be on the same page that obesity is a disease, not a behavioral problem. We will understand how to formulate an effective obesity treatment program with multiple components, know the indications for approved obesity treatments, which includes lifestyle interventions as well as pharmacotherapy and surgical procedures. And we are going to become familiar with recent obesity management guidelines that guide our clinical practice. So for a long time, over a decade, we had no obesity management guidelines. And since 2013, we have been lucky to have these documents, which are extremely helpful in compiling the evidence and guiding our clinical practice. The first document that I'll be referencing today is the American Heart Association, American College of Cardiology, and Obesity Society Guidelines for the Management of Overweight and Obesity in Adults, which was published in 2013. More recently, in 2016, the American College of Endocrinologists also came out with very comprehensive obesity guidelines, and the Endocrine Society has guidelines that specifically address pharmacologic management. So where it's relevant in the presentation, I'll be speaking a little bit about what these guidelines say in terms of guiding the management. The definition of obesity is based on the body mass index. But I like a definition by the American Society of Bariatric Physicians, which is really much more comprehensive and which I think sets us up to counsel our patients in a much more sensitive and comprehensive manner. So they highlight that this is a chronic, relapsing, multifactorial neurobehavioral disease, and that its consequences are not only metabolic and biochemical, but also psychosocial. And the way that energy is regulated in our body is extremely complex. The details of this are way beyond the scope of this talk, but I think it's very important to approach a patient with obesity from the perspective that we have this beautiful energy regulatory systems, and that in people with obesity, we have now come a long way in understanding how these systems become dysregulated, leading to the disorder of obesity. But really, this is a very complex disease where the neurobiological factors are there, and on top of that, can be economic, psychosocial, endocrine, developmental, genetic, and environmental factors, which really all come together to contribute to the development of the disease. And this is probably a different disease with different factors in each individual, which really highlights the complexity of management, and we will be talking about this today. With all of the recent evidence that we have gathered, both in terms of the underlying science and the clinical studies, our paradigms about treating obesity have really shifted through the development of these guidelines. So what we think about now is that really risk, not just BMI, should drive our treatment decisions. We also really need to link weight loss goals to health goals. This is not about a number, but about preventing and improving chronic disease. So we want to intervene earlier and think about obesity management as chronic disease management. And we want to be very personalized and individualized in our treatment approaches, and that's what we're going to be addressing today. One important aspect that I think really highlights the diversity of this condition and the difference in different individuals and why we need to individualize our approach is that no matter what intervention we look at, the biological response is very varied. So when often studies are presented as an average result for a group of individuals that underwent an intervention. But when you look more granularly at the data, whether it's a specific diet or a pharmacotherapeutic agent or an exercise intervention, there's a huge variability in how people respond, with some very high responders losing a lot of weight and others even gaining weight during an intervention. So we're really, this emphasizes that we're really needing to match the intervention to the individual. We know that obesity carries a lot of health risks, but I think a very important question to ask ourselves, and a legitimate question for our patients to ask us, is what are the benefits of health, of weight loss? And probably the strongest connection is with diabetes prevention. So some older data, but very strong data from the diabetes prevention program showed us that when a group of patients with prediabetes underwent an intervention that was an intensive diet and exercise program and was able to obtain on average about 7% of their initial weight loss, they had an almost 60% reduction in the risk of going on to get diabetes. So modest weight loss confers a very profound effect on diabetes risk reduction. Metformin was also effective in diabetes prevention, but not as much, only about 30% reduction with use of metformin. And analyzed a different way, this data showed that the more weight you lose, the more risk reduction you have, which makes sense. This is a spectrum. But what about the important question of whether losing a modest amount of weight, as can be obtained in these intervention studies, affects mortality and cardiovascular disease risk? Well, until 5 or 6 years ago, we didn't have any data to inform this. But since then, data has been coming out, which supports that perhaps this amount of modest weight loss can have an effect on mortality and cardiovascular disease. The Look Ahead trial, which randomized patients to an intensive lifestyle intervention for 1 year but followed them out for 10 years, in fact did not see a difference in cardiovascular death or a composite cardiovascular endpoint. However, even the patients in the control arm in the study had fewer events than was expected for the population. And one interpretation of this data has been that in both the arm that got the lifestyle intervention and the control arm, there was an improvement or a reduction in mortality and cardiovascular disease, and that this happened through more pharmacotherapeutic agents, for example, for cholesterol and blood pressure management in the control arm, and through weight loss and fewer medications in the intervention arm. The Ching study, which was a very extensive long-term follow-up, 23 years, did show a reduction in all-cause mortality of about 30%. And more recently, a meta-analysis of all the randomized controlled trials that have provided weight loss interventions and followed people out for greater than 1 year showed that there was lower all-cause mortality with good quality evidence to support this, a modest effect of about 20%. And there were new cardiovascular events, also reduction, and cardiovascular mortality was lower quality evidence, but still a significant reduction in weight loss interventions. So let's turn now to the clinical tools that we have for treating our patients with obesity. And we're going to be talking about how to counsel our patients a little bit, and then the strategies that we have, which include diet, behavior modification, physical activity, medications, and surgery. So I wanted to say a few very important points about discussing weight with our patients and how to initiate the discussion. We have to really approach it as a complex and multifactorial disease, as we talked about early on, because patients with obesity experience a tremendous amount of judgment and discrimination because of their disease. And so it's extremely important that they feel their providers who's going to be addressing their weight is able to counsel them in a sensitive manner. And a lot of studies have actually been conducted to understand the kind of terminology that patients feel the most comfortable with. And what's recommended is something like, we have not discussed your weight recently. What are your thoughts about your weight and health at this time? So very open-ended, very non-judgmental language. And studies have shown that the patients who have obesity prefer that this is addressed by the term weight. So as I mentioned above, using language that includes weight rather than obesity or other terms that have much more judgment attached with them. We want to use a counseling style that is patient-centered and collaborative, and that could be a whole talk unto itself. But the concept of motivational interviewing, where we are trying to understand people's own motivation for change, is what's preferred and recommended. And we want to really assess an individual's readiness to undertake the measures that are necessary to succeed in this journey. Because if an individual is not ready at this time, then this is not the time that they're going to most likely be successful. So we want to then continue to talk with them and continue to assess their readiness, and then help them at the time when they become ready. As I already mentioned, we want to encourage personal reasons for change. Those are most likely to be intrinsic motivators that are sustained. And we want to really help them focus on non-weight related outcomes, not on a number, but rather on the health improvements that 5 to 10% weight loss can bring. So what are the weight loss goals that we should encourage people to seek? Well, there isn't a clear answer to this question, and for different populations, this may be different. But the AHA-TOS guidelines for 2013 come down on about 5 to 10% weight loss in 6 months. This is based on some of the studies, including the DPP that we briefly reviewed, that showed that this is what's obtainable through lifestyle intervention. So how do we do that? How do we help our patients to lose 5 to 10% of their weight in 6 months? The strategies for lifestyle change that are evidence-based that we will touch upon include caloric restriction, the use of portion-controlled foods, frequent follow-up visits, self-monitoring, including monitoring their weight, their dietary intake, and their physical activity, increase in physical activity, both in exercise and in non-exercise activity thermogenesis, and then putting it all together, a referral to a high-intensity comprehensive program. Let's focus a little bit on the diet. Probably this is the thing that is most written about, and there's so much scientific literature and also lay press about the composition of our diet, and can we find a way to trick the system to eat everything we want and still lose weight? Or are there certain groups of foods that make us feel more full so that we eat in total less? The science is really evolving on this, and it may be that in a few years we do identify certain groups of individuals, maybe certain genotypes, that do better with certain kinds of diets. But when we look at large groups of individuals, in other words, the best randomized controlled trials that we have, there really is no specific diet that works better than other diets. So I'm showing you data here from the Pounds Law study that came out of the Harvard School of Public Health, and individuals were randomized to different quantities of protein, fat, and carbohydrate in their diet. And no matter what macronutrient composition they were randomized to, they all lost about the same, 7% of their initial weight loss. They all regained back a little bit over time. So what we think of right now today is that the bottom line for weight loss is being able to restrict calories and adhere to whatever dietary program an individual chooses. And really, there is no macronutrient composition that is consistently better than any other for weight loss. The AHA-TOS guidelines from 2013 summarize this by saying that we should prescribe a 1,200 to 1,500 calorie diet per day for women and a 1,500 to 1,800 calorie per day diet for men. And I think this is very helpful in clinical practice to have this range, and then it sometimes needs to be adjusted based on an individual's success or results, but this is a very good place to start. And furthermore, they specify that any of the evidence-based diets that restrict certain food types, whether it's high carb or high fat or anything else that creates an energy deficit, can be used as a strategy for weight loss. The concept of meal replacements is an important one as a strategy for helping people to manage weight loss. The idea here is that this is a portion-controlled food, and that the person at the time of hunger or attempting food in front of them isn't deciding how much quantity they're going to eat. Multiple studies, I'm showing you data here from the Look Ahead study, have shown that people who adhere more to the use of meal replacements lose significant more weight than people who don't. Meal replacement can be liquid meals or bars, or even something that a person cooks at home and measures and portions out, and then has kind of only that limited quantity available to them at the time of a meal. This generally can be convenient and inexpensive, and as part of a sensible and well-planned menu, can be a very useful strategy to assist in weight loss. Another thing that's very clear from the literature is that the more frequently people follow up with providers and support systems, the more likely they are to be successful in weight loss. Again, data from the Look Ahead study shows that the people who came to the most visits lost more than twice as much weight as the people who were hardly attending the visits. And multiple studies have shown this. So I think in clinical practice, we have to be creative about how we can follow people and provide more frequent follow-up when they're really engaging with us in a weight loss intervention. So maybe they can come to our office and have a checkup with an MA, a weight check, as they might have a blood pressure check. It doesn't have to be a full office visit with a physician perhaps, but some sort of support structure a little bit more frequently so that they can really have this possibility of the support for success. Self-monitoring is probably the best studied and most effective behavioral intervention. And this works with good old-fashioned pen and paper. The old studies, people just wrote down on a book what they were eating. And now we have a lot of different apps that can help patients to do this. And not only do they record what they're eating, but they get back a lot of information about the content, the calories, the protein or carbs in the food that they're recording. But the key thing is the behavior part. If you bite it, you write it. And adhering to that really helps people to change their behavior. It's a very important self-reflection. It brings a lot of mindfulness to what they're eating because they've committed to writing it down. And people start to really learn and to really change their behavior as a result of logging. And often when people have initial success and then stop logging and then they reach a weight plateau or they're regaining some weight, we recommend that they come back to the basics, such as committing to the self-monitoring daily, and really see that this helps them to start to lose weight again. Exercise, of course, is a very critical part of the weight loss intervention. And interestingly, exercise alone in interventions doesn't usually cause a lot of weight loss, but it does augment the dietary strategies, and it's very important for weight loss maintenance. So the more exercise that people do over time, the more likely they are to maintain the weight loss. And just as exercise is very important, not being sedentary and the concept of non-exercise activity thermogenesis is important as well. And a pedometer can be a great way that people can increase this if they set step goals and work on increasing their step goals as time goes by. They can really increase the amount of time that they're moving rather than sitting and augment their weight loss success. But the most successful way to lose weight is to put all of this together. So the AHA TOS guidelines kind of summarize nicely that high intensity comprehensive program is the best chance that people have at success here. The intervention is most effective when delivered in person, although telephone and internet also work. When it is high intensity, defined as greater than 14 sessions in 6 months, and should be either individual or group sessions by a trained interventionist. And the principal components should include the things that we've been talking about: the reduced calorie diet, the physical activity, and the use of behavioral strategies to facilitate adherence. I'm going to turn now to weight loss medications. What are the medications that are approved for weight loss? When is it appropriate to consider use? And which meds do we use for which patients? Quick question. I'm confused because I have 2 different timers going on. Does this say that I've been talking for 24 minutes?
I'm sorry.
That I have 24 minutes left?
It's a countdown.
Okay. So, okay, fine.
You want me to do it the other way?
No, it's just that this one is saying 38, so I'm like, like every time.
As soon as you open the presentation.
It goes. Okay. So this is how much time I have left.
Yes.
Okay, fine. So I'm doing fine. Absolutely fine. Okay.
So you're going to start over on the slide, or have you already?
No, I finished the slide and then I kind of paused. I did a long pause before I asked the question.
All right.
The most important thing that I want to convey about the use of weight loss medications is that they are an adjunct to diet and exercise. The idea is never that someone walks into an office, gets a prescription, and doesn't come back for another year. The idea is really that when someone is engaging in the kinds of strategies that we've been talking about, modulating their diet and their physical activity, and they are not seeing results, we have this as an additional therapeutic tool to add to that. The indications for the use of weight loss medications are a body mass index above 30, so the definition of obesity, or above 27 if they have already developed comorbidities related to their excess weight. And the guidelines, again, are clear that if an individual has never participated in a comprehensive lifestyle intervention, then that is the first thing that should be done. It's really for people who are unable to lose weight or to sustain their weight loss. So for example, someone who gives a clear history that they've had multiple successful attempts at weight loss, but then weight regain over time, then they can be considered for adjunctive therapies such as the pharmacologic intervention. We have multiple agents available on the market for weight loss, and I'm just going to take some time to review each of them briefly and to kind of outline a strategy for when we can best consider each therapy. So phentermine is the oldest drug that we have available on the market. It is an amphetamine derivative, so it can increase heart rate and blood pressure, and we have to be extremely careful in people with a history of heart disease or strokes. And my practice is generally not to use this medicine in those individuals, although the more recent FDA regulations for the combination of phentermine with topiramate say that they shouldn't be used in people who have had an event within the last 6 months. Phentermine can be combined with topiramate in what is a synergistic relationship, and so the medications together cause more weight loss than each medication alone. Sometimes topiramate is also used off-label for weight loss. They are marketed together in a specific extended release dose combination marketed as Qsymia, but they're also available separately on the market. And when you take both medications, you can have the side effects of both medications. So the phentermine we've reviewed, topiramate, can cause some cognitive effects and some tingling, and is a teratogenic agent. So special care has to be taken in women of childbearing age. But the idea with a combination of the drugs is you can take less of each one and therefore have fewer side effects from each one, but have an augmented effect by the combination. Another drug available on the market is lorcaserin. The weight loss is more modest, but as we'll see, we have some very exciting recent data from a cardiovascular outcome trial. It works through the serotonin pathway, and so it's not recommended for co-prescription with SSRIs because of the theoretical impact or possibility of serotonin syndrome. And it is now also available as an extended release once daily preparation. Orlistat is the only agent on this list which is not a central acting appetite suppressant. It's a lipase inhibitor, so it causes fat malabsorption and has a very unpleasant side effect of steatorrhea. It's available over the counter in a lower dose, but it's not used very frequently in our practice because patients really don't tolerate it well. Naltrexone and bupropion, two medications that have been on the market for other indications for a long time, were combined successfully in a brand name medication called Contrave, which causes also modest weight loss, but can cause a significant amount of nausea. Again, the brand name pill can be prescribed, or the two drugs can be prescribed off-label as generics together when there isn't insurance coverage is usually when we have to do that. And finally, liraglutide, which has been on the market for a long time for diabetes, has more recently been studied at a higher dose for weight loss, even in people without diabetes. And it does not cause hypoglycemia, but it is very effective in appetite suppression and in inducing weight loss. You can see that with medications, the range is about 5 to 10% of weight loss. These are percents of weight loss more than the placebo arm in the study lost. And so the effect is modest, but in some people, as I mentioned earlier in the talk, the effect is more robust because they're high responders. The corollary to that is other people simply don't respond at all and don't lose weight or feel an effect. So how do we choose which medication for each person? Well, the first thing I consider is effectiveness. You can see that there's a range where some are more effective than others. And so if we have all choices, I would choose one of the more effective ones to start with. There are a lot of contraindications. And so if a person takes certain medications or has certain medical conditions that rule out the use of a certain medication for weight loss, then that would be a reason not to choose that agent. And then we try to be thoughtful about, could we use a medication that helps an individual with multiple medical problems? For example, topiramate is also used for headache prevention. So if the person presents for weight loss and is also reporting a lot of headaches, that might be a good choice. For liraglutide, as I'll show you, there's excellent diabetes prevention data in those with prediabetes, so that may be a top choice. Another very important factor is cost. If these drugs are not covered by insurance, they tend to be very expensive, and so sometimes needing to work with generics determines the course of treatment. And then, of course, patient preference, and this is most important because one of the agents, liraglutide, is a subcutaneous injection, so a patient has to be willing to do that. But also because these drugs are now marketed heavily to consumers, and sometimes patients come with a specific idea about a medication they want to take. This is a chart that shows how different the average effect of these medications are. So you can see that the combination of phentermine plus topiramate is the most effective, and the next most effective is liraglutide at the weight loss dose, and then there's a range in between. So this is part of how we determine which drug we use. And then I've highlighted in this table the kind of major contraindications or cautions with each drug. So in someone who has kidney stones, you would not want to prescribe phentermine and topiramate, which can increase the risk of kidney stones. We have to be careful when there's renal or hepatic insufficiency. I mentioned lorcaserin and the co-prescription with SSRIs, etc. It's very important to follow people very closely if you're going to use these agents in your practice. And what's recommended is that they're assessed monthly for the first 3 months of use of any medication, and then every 3 months. And a key thing that has come out of recent data that led to the approval of all these new agents is that it's very clear that if the weight loss agent is effective for an individual, and that's defined as 5% weight loss at 3 months, then the medication needs to be continued for continued efficacy. In most studies, when the patients who get drug are re-randomized to a placebo extension, they gain back most of the weight. So this is kind of similar to how we think of antihypertensive agents. If the patient doesn't take it, then the drug is not going to be effective. We need continued use for continued effect. But the corollary to that is that if a medication or an agent is ineffective, they don't lose 5% at 3 months, then we really need to discontinue the medication, and we can try an alternative approach, but we don't want to continue someone on a medication that's not effective. I want to show you very briefly the data for liraglutide and diabetes prevention. It was really a remarkable effect where people who started out with prediabetes and took this medication had an 80% reduction in risk of going on to get diabetes. And then very recently, we had the publication in the New England Journal of Medicine of a cardiovascular outcome trial for lorcaserin. This is the first report of cardiovascular safety of a pharmacologic strategy. 12,000 patients got this drug, and the results showed that there was no increase in cardiovascular risk. So taking this drug in patients with high risk, because they all had established coronary artery disease or multiple risk factors, did not lead to an increase in events. However, it also did not lead to a decrease in events. So the modest amount of weight loss that this population was able to achieve did not reduce cardiovascular mortality or other cardiovascular events. There was about a 20% reduction in the development of type 2 diabetes. Okay, I'm going to turn briefly now to bariatric surgery, which is the final kind of group of interventions that we have for the treatment of obesity. The indications for bariatric surgery are a body mass index above 40 or above 35 if an individual has comorbidities of obesity. As I tell my patients, this is the most effective therapy that we have to offer patients with obesity. And the reason that I say that is that the magnitude of weight loss and the likelihood of successful maintenance of that weight loss over time is clearly greater with surgery than with any other therapy that we have. There are multiple surgical approaches. What's mostly being done in our center and in the United States is the sleeve gastrectomy, with some still good percentage of patients undergoing Roux-en-Y gastric bypass, very few undergoing the band now because of a high percent of not deaths, but other more minor complications that require removal of the band. And you can see that over time, the trends have really shifted towards more sleeve gastrectomies and fewer bands and fewer gastric bypass. There are some differences between the surgeries. There's a little bit more excess weight loss with gastric bypass and a little bit better diabetes improvement, but it's also a more morbid surgery with a little bit higher risk of complications and a more difficult operation. And a very key point about surgery is that for patients who have both type 2 diabetes and obesity, this is a very effective approach. And now we have multiple randomized controlled trials comparing a lifestyle approach with a surgical approach that have shown that over time, patients are more likely to have remission of diabetes, improvement in their A1C, and maintenance of weight loss compared to lifestyle interventions. And we now have 5-year follow-up data from randomized interventions that supports this sustained effect. Whoops. But people who undergo bariatric surgery need lifelong care. And I think for any clinician who will be seeing more and more patients, not only kind of advising them through the course of getting to surgery, but also seeing them afterwards for medical care, it's very important to understand the kinds of long-term complications and lifelong care that post-bariatric surgical patients need. So micronutrient supplementation, this is a huge issue. It's true for sleeve gastrectomy and for gastric bypass. Patients need ongoing multivitamin supplementation, iron, folate, thiamine, calcium, vitamin D, B12, iron. These are micronutrients that can certainly become deficient and profoundly so without supplementation. And so there is a requirement for lifelong screening. In the beginning, we do it more frequently and then we push it out to annually, but we need to continue to monitor micronutrients, and there has to be a lot of care to avoid NSAIDs, which can cause anastomotic ulcers, tobacco, and no pregnancy for 12 to 24 months after surgery. This is an issue that is under ongoing study. Okay, so let's summarize what we've learned today by asking a few questions and seeing if we can come to the right answer. So, based on what we've discussed today, which of the following is true regarding lifestyle interventions? A, guidelines suggest prescribing caloric restriction for weight loss, 1,200 to 1,500 calories per day for women and 1,500 to 1,800 calories per day for men. B, guidelines suggest that a low carbohydrate, low glycemic index approach is preferred for diabetes risk reduction and longer term weight loss maintenance. C, self-monitoring by tracking food intake is associated with successful weight loss, but monitoring weight itself is associated with worse outcomes. Or D, physical activity can augment weight loss, but beyond 150 minutes per week, little added benefit is observed. The right answer is A. Hopefully everybody was able to come up with this. And as we discussed earlier in the talk, at this time, the available evidence that we have suggests that caloric restriction and adherence, but not a specific macronutrient composition, is what matters the most for weight loss. And to address the other wrong answers, hopefully you'll recall that we discussed that monitoring weight, food intake, and exercise are all recommended as part of lifestyle interventions. And studies do support that the more physical activity, the more weight loss and more weight maintenance over time. I showed you that study where those who were doing over 300 minutes per week had the best success at 2 years of follow-up. Another question. Which of the following is recommended regarding weight loss medicines? A, discontinuation of the medication once the patient has lost 5% of initial body weight. B, discontinuation of the medication after 3 months, regardless of whether it's had an effect or not. C, discontinuation if the patient does not lose 5% of the initial body weight at 3 months. Or D, change to use the medication as needed once the patient loses 5% of initial body weight to lower exposure and risks of any therapeutic agent. The correct answer is C, discontinuation if the patient does not lose 5% of initial body weight at 3 months. I hope you'll recall that what we discussed is that patients on weight loss medications need very close monitoring, and that there's a lot of biological variability in response to any pharmacologic agent and also any lifestyle intervention as well. But if one approach is not working for an individual, it needs to be readdressed. So if a medication is not resulting in 5% weight loss at 3 months, we don't want to continue to expose the person to that agent that is not resulting in weight loss. They are a non-responder, and an alternative should be sought. And then I also want to highlight again the point that I made earlier, that at all visits there should be an emphasis that medications are an adjunct to diet and exercise. So we want to be sure that we're doing everything we can to help the individual stay on track with their diet and with their exercise, even if they're taking a medication to help with weight loss. So in summary to today's presentation, we've taken the approach that obesity is a disease with underlying neurobiological components and a lot of complex societal and environmental influences as well, but this is not a behavioral problem that we blame patients for. And when we approach it that way, I don't know, I lost your advice and I used the thing. So let me start again from here. Is that okay?
Sure,
okay.
You're going to start at the beginning.
Here, of the slide, yes. So in summary to today's presentation, we have taken the approach that obesity is a complex disease with neurobiological underpinnings and then a lot of societal and complex multifactorial, I'm going to start again because I lost my mojo here. In summary to today's presentation, we have taken the approach that obesity is a disease with neurobiological underpinnings, as well as very complex societal, genetic, environmental, and other aspects, but it is not a behavioral problem that we blame patients for. And because of this, we do not have a one-size-fits-all approach to obesity, but rather we need to form a long-term relationship with our patients and individualize our strategy for each individual. The goal of medical interventions is 5 to 10% weight loss at 6 months. And we're going to use strategies of calorie restriction, of behavioral modification, and of exercise to achieve this. And when these are not successful or not sustained, we also have medications which can serve as an adjunct to lifestyle therapy. And when we use medications, we need to reassess their effect continuously and decide whether we need to continue because of good effect or discontinue if ineffective. And we also have surgical approaches to obesity, which are highly successful in terms of magnitude of weight loss and maintenance over time compared to other strategies. Surgical approaches include gastric bypass and sleeve gastrectomy, and they are particularly effective when there's comorbid type 2 diabetes and obesity. And there are a lot of guidelines for review, so I invite everybody to review the references that I have provided, which include the guidelines I mentioned in the beginning of the talk, as well as guidelines for perioperative management and a excellent review in the New England Journal of Medicine on the mechanisms, pathophysiology, and management of obesity. Thank you very much.